awareness that it can go from one place to another, and that is the real problem, that it can spread. And people began to perform surgery, even then, even in the time of the Greeks, to try to remove it. So the initial therapy was surgery. By the beginning of the 1900s, we actually began to do radiation therapy. This was after the observation at the end of the 19th century that X-rays could have impact on biological tissue. And the way the testing was done is that the cathode, the area that was projecting the ray, people would put it on their skin. The radiation oncologists, they didn't call them that, they called them just radiologists then, but they would put it on their skin, and they would find the dose that made the skin red. So they called it the erythema dose. And it was thought that the erythema dose, that's the dose for the patient. And you can imagine, because people were testing the radiation on themselves, that many people had developed leukemia after that experience. So the very beginning of radiation, the 1900s, and the reason I'm showing you this is to tell you the tremendous amount of progress that's happened in this most recent period of time. Chemotherapy wasn't really a concept until after World War II. And if you've read The Emperor of All Maladies, it really has a very nice description of these. But that the exposure to mustard gas seemed to impact the bone marrow. And we had really observed, clinicians had already observed, that changes in the bone marrow is what happened with some cancers. That's what happened with leukemia. So in Boston, Dr. Sidney Farber put together this compound that was based on these tools of war to really develop a treatment for children with leukemia. And in 1948, in the New England Journal of Medicine was the very first publication that said this treatment on 16 children resulted in 10 temporary remissions. Incredible, had never happened. So not permanent, temporary, but had never happened before. So surgery, radiation, chemotherapy as concepts began to emerge. And today, there are more than 17 million people that are surviving, that are living with a diagnosis of cancer. So I want us to go back to then really think about what is cancer. And again, like I said, this is going to be sort of a foundational conversation where we begin to talk. So there are cancers that begin in the solid organs, the lungs, the breast, the colon, for example. There are cancers that begin in the blood. There are cancers that begin in the lymph nodes. And there are cancers that begin in sort of the connective tissue, the bones, the muscles, the fat. And they each have different types of names. So carcinomas are solid tumors. Blood cancers are leukemias. Beginning in the lymph nodes are lymphomas. And beginning in fat, bone, muscle are the sarcomas, okay? So that just gives you kind of a map of where are we with this thinking. So cancer can kind of begin anywhere, but the characteristic of cancer, and to me, again, I just think the body, it's just incredible. So our normal cells divide, grow, and die. That's it. It's just the normal process, okay? Cancer cells, there is a molecular, a biological, a genetic problem that happens to that cell, that it only grows. It doesn't die. And I remember when these papers initially came out that the characteristic of a cancer cell is it forgets to die. And from that process, it just begins to invade, okay? So whether in the blood, whether in the solid organs, wherever it is, that's what we're talking about. Now there can be growths in the body, and some of us, we may have little spots. People commonly have lipomas, little fatty growths that just hang out. They're benign, okay? They're local, they're not spreading. The characteristic of a cancer is the uncontrolled growth, and uncontrolled growth that then invades. And that invasion is either through the bloodstream, through the lymph system, which goes throughout the body. And all of this takes time. So I want you to remember that, because there's a lot that could be done during that time. So what's the problem? What's the problem? Why is this an issue? And the issue is, for example, for breast cancer, or here the slide of melanoma. Let's say there's a melanoma somebody had in their shoulder. The problem is those cells, they grow, they divide, and then they get loose in the bloodstream. And then they can take up home in other places. So here actually they drew the melanoma, but it's taking up home, for example, in the liver. So we like to try to get things when it's local, when it's circumscribed. We can either do surgery, radiation, chemotherapy, get rid of it. It's more difficult when it has gone to another part of the body, where it has taken up home in other parts of the body, okay? So that's the danger. If breast cancer stayed in the breast, not an issue, but it invades, goes to other organs. So when we do a diagnosis of cancer, find some abnormality, this goes to the pathologist. And today, it's not just looking under the microscope and identifying the different looking cells. It's often also looking at the genetics of the cancer. So there's the genetics of the person, right? The hereditary pieces, but there's also the genetics of the cancer. And that's the molecular biology of the cancer. And we'll talk more about that and what that means. So the pathologist looks at the tissue, and this, I really like this schematic. And again, it really is beautiful, because you can see the normal tissue, and the normal tissue is beautiful. It's well organized. It's beautiful in color. The cancer tissue, you can start to see, and this side of the diagram is, can you see my arrow? Oh, I'm pointing at the wrong. Did you see my arrow now? Oh, so you're actually seeing the other screen. That's okay.
Yeah.
So when you see the disruption, that's when you start to see that there's abnormalities. Eventually, the abnormality of the cells, and they're cells that are dividing. So that makes them irregular. You see the nuclei, which is where the portion where the DNA is of the cancer cell. You see them in variable shapes as opposed to the nice uniform shape of the normal cell. A normal cell has a nice even spacing of the cytoplasm around the nucleus. You don't see that. So you really do see that the abnormal cells look abnormal. They just don't look normal. And this is called, so in addition to the cancer cell, there are cancer cells that look more normal, and there are cancer cells that look more abnormal. And that's the grade. And that usually goes with how quickly it is dividing. So it could be dividing slowly, looking more normal-like, or quickly, looking more abnormal-like. And that's what's called the grade, okay? The grade tends to have a better prognosis, the lower grade. The higher grade has a more worrisome prognosis. So how does this happen? How do we get cancer in the body? And there are lots of factors. There's lots of carcinogens. There can be viruses, there can be bacteria, there could be radiation. There's our own genetics. There's what we eat, exposures through hormones, it's chemicals. So there's a variety, there's a blend. And often what we're thinking about, those of us who are interested in preventing cancer, is it the genes? Is it behavior? Is it the environment? Or is it some interplay of both? And one of the ways that we understand this, or that we think about this, is because people move. And so, for example, in Japan, there's very low colon cancer. And when people move, it increases. And so then we begin to think, well, maybe there's diet issues. And similarly, there's high stomach cancer. And when people move, it decreases. So we really try to figure out what are those factors that are making the influence? What are the factors that we may be able to control? What is in our control to prevent? And I'm just going to go over a few of these. Smoking. Smoking is huge, right? If you can do one thing, don't smoke. Sun exposure, radiation exposure. And radiation exposure isn't only because people get radiation, it's also radon. There is natural radiation in the environment, and in some places more so than others. Viruses, HPV and cervical cancer, HPV and head and neck cancer, hepatitis. There are viruses that are integrated into the cell. So it's fascinating, right? A virus can only live by integrating into the host DNA. And when it does that, it can transform the cell into a cancer. Bacteria. Stomach cancer is related to H. pylori. If we eradicated the infection of H. pylori, we might eradicate stomach cancer. Again, the first time I heard that, it like blows your mind. Think that you could treat an infection and prevent a malignancy. And genetics, for example, for breast cancer, for ovarian cancer, identifying the genes that are causing the cancer. Here again, the point of time. Smokers, lung cancer incidence. There's about a 20-year lag between the onset of smoking and the onset of cancer. What I think about when I hear that is there's 20 years to try to prevent it. So best is never to start, but we can try to prevent. And I also wanted to bring this up here because there are now ways to screen for lung cancer. So want you to think about that for whether it's you or your loved ones. Screening, which is a way of identifying cancer before there are symptoms. Breast cancer, cervical cancer, colon cancer, prostate cancer, skin cancer, and lung cancer are the screenable cancers detected before there are symptoms. So now that was just my little aside on screening. Here are some of the viruses. We talked about HPV and cervical cancer, head and neck cancer. We talked about hepatitis, liver cancer, Epstein-Barr virus, Burkitt's lymphoma. So this association between viruses and cancers, very important. Genetics, we mentioned breast and ovarian, but there are different syndromes that can be associated with colon, rectal, some pediatric, some retinoblastoma, some pediatric cancers as well. So very important is to know your family history. What did people have? And if it looks like there are many people that have had cancer in your family, or if there are many people that have had a specific type of cancer, talk to a genetic counselor and understand your risk. But first is know your family history. So how all of this happened is because the chemicals, the viruses, the radiation, the infections the hereditary factors, this is impacting the genes. Now this again, we're not talking about the genes that you are carrying and passing on to your children. These are the genes in the body, the DNA in the body, and how that may lead to cancer. And that is really that since the year 2000, that is where our knowledge has really whoosh, exploded. What happens? The DNA, we could lose just one gene. We could lose just one change, and that might be enough to have a mega change. Sometimes there are additions of base pairs. Sometimes there are deletions of base pairs. Any of these factors, and you have to think these happen all the time, but some are significant and some are not. So it's like the body gives you a cushion for these changes to happen, but sometimes they happen in areas that make a difference. So how does this happen? You have the normal cell, and these are just different ways. You have a normal cell. The normal cell is going through its usual growing, dividing, and dying. Growing, dividing, and dying. And in the normal cell, there's a gene that says you got to go through that cycle. You got to the cell growth is regulated. And for whatever reason, a virus, radiation, for whatever reason, a gene gets mutated. And for whatever reason, that gene is not repaired. So now you have a mutation. And that gene that organized, that regulated the cell growth can no longer do that. So the cell just grows, okay? So that's one possibility for the problem to begin. There are normal cells that not only regulate the growth, they're actually preventing cancer cells from showing up. So these are tumor suppressor genes. And if that, whatever's bringing in the onset of the mutation, infection, virus, a predisposition from a hereditary factor, that results in a mutation, that tumor suppressor gene is no longer working, where it's now inactivated. It can no longer suppress tumor formation, and this unregulated growth happens. And the most important, most significant, there is a protein called P53. When we were studying pathology, we used to call P53 the master of the universe, because P53, so incredible. A normal cell, it happens all the time, right? We live, and in living, we're exposed to all sorts of things, mutations happen. P53 goes around and says, okay, you've had too much damage. It's time for you to die. So it's an incredible regulator. It identifies cells that really, they've had too much. They need to be deleted. And when there's a mutation in P53, when P53 can no longer do this regulation, then these cells grow, and that can lead to cancer. So P53, so oncogenes, meaning genes that are regulating, tumor suppressor genes, they're suppressing the growth. P53 mutations, these are all ways in which our DNA can get impacted. And there are incredible genes in our body that their only job is to repair the DNA. That when these things happen, they're just going around and saying, oops, you got a mismatch, let's fix it. And they fix it. And as long as this is happening normally, it's the changes are preempted. It's like, get back on course, you're okay, get back on course. But if there's a mutation in a DNA repair gene, the mutation happens, the change, the mismatch happens, and there's no DNA repair. And then cancer cells can arise. So understanding the molecular biology, understanding the genetic changes that are happening in the development of cancer has been critically important for us to understand not only the development, but also how cancer spreads. And again, remember, this takes time, and this often takes multiple mutations. This has been really well worked out for colon cancer, where you can see these are the types of mutations that happen early, middle, and late. So it gives time for us to try to rectify whatever exposures we're having. It takes time for us, gives time for us to identify disease early. All of these are opportunities for getting people to better health because it takes time. So much better to catch something in here, right? Screening, prevention, so important. So what can we do? Again, smoking. Smoking impacts the entire body. We think a lot about lungs, right? But we think lungs, we think throat. Tobacco carcinogens are found in the cervix of women that smoke. It goes through our entire body. And when you combine carcinogens, the combination of alcohol and cigarettes, for example, can really increase the risk of the disease. There's a lot that's been written about red meat. You have to think, I don't know how much you can see me, but a huge portion of our body is devoted to digestion. We basically are digestive machines. A lot around red meat. Some of it may just be because of the food supply and the carcinogens that we've allowed to enter the food supply, but there is an association that places that eat more red meat tend to have more cancer. So something to be cautious about, okay? Fruits and vegetables, especially vegetables. I always talk to my patients when we talk prevention, primarily vegetable diet. Change your diet to a primarily vegetable diet. Cruciferous vegetables, broccoli, cabbage. Yes, they may give you a little gas at first, but make the changes slowly can really help from a prevention standpoint. Sun exposure, radon exposure, have your homes tested is another way. Thinking of the carcinogens, asbestos, benzene, you know, when we did chemistry in the lab as undergraduates, I'm sure we were exposed to benzene. There were not much precautions then, but to be aware, I think the biggest thing is be aware. Be aware of what you're eating, be aware of what you're exposed to, and as much as possible, protect yourself. We talked a little bit about HPV. There is a vaccine. There's a vaccine for hepatitis. Having vaccines that can help prevent cancers, it's an incredible opportunity. So really important for us to think about all of these factors to maintain health. So what is cancer? Uncontrolled growth of a cell. Our cells are meant to grow and then to die in a normal process. Genetic molecular changes disrupt those factors. By understanding those genetics and molecular factors, it's really given us the opportunity to identify specific targets for prevention and for treatment. That has been the biggest revolution of the last 20 years. So today, we look at the cancer cells under the microscope. We see Mrs. Smith's and Mr. Jones' cancer cells may look really similar under the microscope. But when we look at the molecular biology, at the genetics, we may find specific changes that could be specific for that person. So that's what we're working on. That's what has really allowed the possibility of having 17 million survivors. But we also really want to work on prevention. So thank you for your attention, and I'm happy to take any questions as you have. Thank you.
Thank you, Dr. Lopez. That was wonderful. Okay, so I think we're going to do the questions at the end. And I appreciate you staying within your time limit. That's wonderful. Thank you. All right, Reverend Percy McCray, are you ready to give us an overview and a little bit of discussion about the Our Journey of Hope ministry, please?
Yes, ma'am.
Okay. All right, take it away.
Well, thank you so much for the opportunity. Again, good afternoon to everyone, and I hope that you're having a blessed and pleasant day. Again, to the distinguished members of the panel, specifically the clinical representatives, as well as the clerical representatives. I'm privileged to be with you today. I am Reverend Percy McCray. I hope that my volume level is sufficient. I can certainly, good. With that being said, I am Reverend Percy McCray. I'm the National Director of Faith-Based Programs at Cancer Treatment Centers of America, and I oversee the Our Journey of Hope Cancer Care Leadership Training Program. And so first, let me say thank you to Ann Perillo, who has invited me and graciously allowed me to have a little bit of time today to just give a brief overview. And then thank you to Dr. Lopez for her wonderful presentation. I appreciate that clinical succinctness of really helping us to understand some of the basics with regard to cancer. Our Journey of Hope, I'm here to discuss with you and give you a quick overview. I don't have any slides. I didn't want to inundate you with a lot of visual information, but very quickly, Our Journey of Hope is a free cancer care leadership training program. I started this program back in 2003, and based upon the request of a particular patient that I was supporting at that time, started my career in the cancer care community as a hospital chaplain, and then became the director of chaplains. And on one fateful day, had a conversation with one of our patients, and as a result of the pastoral care support and kind of intentional pastoral care support, I should say, that she received bedside inside of a clinical environment, she felt impressed to ask if I would be willing to sit down and have a conversation with her local pastor and the consortium of ministers that he belonged to share some of the insights from a clinical care perspective of the role and value of pastoral care and spiritual support. And so began basically going to any church that would allow me to kind of set up a little PowerPoint presentation and basically unpack some things around the subject and the conversation of cancer, but be more specific around the idea that local faith communities and churches and parishes needed to get involved and be involved and engaged with this conversation to provide deliberate support to members of their faith community. And thus, the birth of Our Journey of Hope began on that fateful day. Just to give you some perspective and scope of the reach of this program to date, we have now trained over 2,000 churches on 5 different continents with our curriculum that is designed specifically for the faith community. And as a caveat and disclaimer, the Our Journey of Hope program is not designed to replace clinical care and good medical care. It is to be an adjunct and a support to and of a clinical pathway and an environment where one is processing through the clinical journey of pastoral care. And it's an important distinction because we certainly still have some schools of thought there that from a faith perspective or a faith-based perspective, from a theological intentionality, that spirituality, faith, and commitment to God in some cases has been presented to replace clinical care or medical care. So I want to be absolutely clear that that is not the intent or the design of this program in any way. It is intended to be and to work within what we call an integrative model of care. And again, to work in partnership and orchestration with the idea of individuals pursuing good clinical medical care and then being supported from a spiritual care perspective with some principles and precepts that will allow their sense of spirituality and faith to be amalgamated with their clinical experience. So again, not to replace, but to be an adjunct and a support to and of. Having said that, as was spoken earlier today in the introduction, I believe that there are 8 parishes in your local diocese that has already received our Journey of Hope training. And the goal here is to expand that and to certainly bring more of the parishes in your diocese into this experience. And so with that being said, a quick overview of the program. We have 8 chapters of a curriculum that will be provided at all of our trainings. They're all online, virtual, and they are all free. All of the materials that we provide to the training cohort are all free. There is zero fiduciary requirements to receive and participate in this program, and it has been so from the very onset. It was my intention in the very beginning when we started looking at this is to provide some community education to the faith community, because at least at that particular time, there was no such healthcare organization that really focused on or participated with the intent of partnering with the faith community. And what we know and what we knew of the purview and the milieu of individuals within our clinical environment, that there was somewhere in the neighborhood of about 75–80% of our patients express some sort of faith orientation or spiritual support desire. And so we began to look at what was available in the marketplace, if you will, and the public square of training information that could be made available to the faith community that will allow that local faith community to participate and engage actively with their members of their faith community in a way that would be of value and benefit to them, and found that there were none. And to this date, I'm not sure if there are many even at this point. So our Journey of Hope's intention was to fill a vacuum and a gap. We did some survey polls of pastors throughout the United States and to get a sense of thought and perception around the idea of cancer, ministry, and support, and found that many pastors felt very inequipped to be able to speak to the subject of cancer. They did express to us that of 3 major categories that they spent most of their time providing some sort of support to their local faith communities were finances, marriage and family counseling, and dealing with the issues of sickness and disease. And of that category of emphasis that they spent a great majority of their time providing support to, they felt the least equipped to be able to speak to the healthcare component, and particularly specific to cancer. As Dr. Lopez referenced earlier, it has now been deemed that cancer is the emperor of all maladies of our day. And prior to COVID-19, it was primarily the healthcare conversation that was probably greatly discussed, more so than any other healthcare challenge in our community and our world. And so we know that there is a need. We know that the need is great, and therefore we have established a working program to help equip local churches to begin to partner and to be engaged actively with members of their faith community called Our Journey of Hope. So a very quick overview of our 8 chapters that's built into our curriculum is that we talk and discuss and unpack with our cohort about how great the need is. We help share some data, some statistics that Dr. Lopez actually went over earlier in her presentation, of just the numbers, the raw data of how many people in our country and our world are being impacted with cancer, how many people are living with cancer. One of the good pieces of that information is that we have seen a decline in how many people are actually dying from cancer. And so that's really good news. But again, we want to give our cohort a sense of what does the data tell us about this disease. And then in our second session, similar to some of the slides that was presented today, about understanding and knowing our enemy. One of the big dynamics is that many of us are we've been conditioned to be afraid of the conversation of cancer simply because of lack of knowledge. And we know that the Bible tells us that my people will perish because of lack of knowledge, or destroyed because of lack of knowledge. So we provide some practical insights, and we have some of our clinical oncologists that provide, again, some working information similar to what was discussed earlier today about what is cancer, how it functions, how it moves, mutates, apoptosis, et cetera, that was discussed in the earlier slides. We provide that information and allow direct interaction with a medical oncologist who will help unpack some of that, the mystery, if you will, and in some cases, some misnomers about cancer and what it is and what it isn't. We share information about do's and don'ts. There are some important things to know with regard to engaging with cancer patients and their caregivers on things that we should do and things that we should not do, particularly with regard to hospital visitation, as an example. There are some protocols and some things that everyone should be made aware of when engaging with individuals within a healthcare visit scenario. We talk about overcoming fear. We talk about techniques and principles about caring for the caregivers. Practical ministry that will allow any faith-based organization with a group of people to be trained and oriented around this program to really engage and connect with individuals within your local church community and their caregivers in a way that will be meaningful and effective, so that you feel equipped and empowered, and the members of your local church feel connected to in many cases, one of the most important relationships that they may have, and that is with their local church community. And so our journey of hope is not designed to replace the pastor or the priest of any local congregation. It is designed to be a supplement and to provide tools that you can put in your toolbox to begin to start and engage in active cancer care ministry inside of your local church. Individuals will come to the training. They will receive all of the resources, and because of COVID, everything now is all online. All of our resources will be made available to the graduate cohort online that they can download and that they can make copies of and provide to their respective teams that they will recruit to begin to train them in an 8-week curriculum that will begin to allow them to reach out to members of your local church in a very expeditious fashion, and provide them really with confidence and a sense of a wherewithal that will allow them to engage and apply whatever your spiritual precepts and principles are with regard to your local church, your local theological perspective, with practical tools and resources to support cancer patients and their caregivers. And so with that, that's the basic overview. I'll stop there. I want to be respectful of the time constraints that I was given, and I'll answer any questions that did not get addressed in any of those speaking points, and I'll fill in and color in anything that is necessary for further elaboration. You can go to our website, ourjourneyofhope.com, and we have some scheduled training sessions that you can sign up for and register for free, again, online, ourjourneyofhope.com. That's all of my time, and I certainly thank you for yours. God bless you, folks.
Thank you very, very much, Reverend. That was wonderful. Both presentations had unique perspectives, but were very impacting and very well presented. So thank you both.
You're welcome.
All right, Anne, I'll let you take it away if there's any questions.
There's a few things on the chat, and one is, can you share the PowerPoint slides? And also to let you know that this is also being recorded, so you can view this later at a later date. The slides will be on that also.
What I'll do, if it's okay with you, is Nicole send you it isn't from the NCI. Okay. I just took like a portion of it.
Okay.
So I'll send you the link so you can have the whole thing.
Absolutely. Thank you very much, Dr. Lopez.
Sure.
Thank you. I can follow up with an email with that information.
Mm-hmm.
Dr. Lopez, your presentation was both extremely interesting and inspiring. She will use this role as a parish nurse in her parish, in a nurse community. Also, I listed Reverend Percy McCray's link, so you could sign up for the newsletter. And then you'll get all his newsletters on a monthly basis. Is it, Reverend Percy? It's monthly, right?
That is correct. Monthly, and again, all free. Absolutely.
Yep. So you'll be included in that email, and it's really got some great things in there. You also have a podcast too that is on that website also. So
Yes.
tune into that. Does anyone else have any other questions or comments?
Hi, Ann, it's Ann Delegaski. I'm a cancer nurse with Dr. Lopez, and I'm also a parish nurse from St. Mary's in Gloucester. So Nicole and I kind of work together in this. I just wanted to make two comments. First, to thank Dr. Lopez and Reverend McCray. And it was a really, in my heart, I've been a cancer nurse for, with this group, I can't say it's more than you've been alive because it's an older group. Usually I'm speaking to people and they're much younger, and I've been a cancer nurse for 40 years this year. So it's a long time. And Dr. Lopez's presentation just made me see where we were before and where we're at now. And it is so very, very, very different, in terms of symptom management and treatment, and all those commercials you see on TV are all coming out of the stuff that Dr. Lopez talked about. So our care of these patients are tremendously different. I serve a second role at Jefferson as a volunteer and Eucharistic minister. And Reverend McCray can tell you that I go into the room and tell people it's the best medicine that we have, spirituality and religion. And I can tell you that it makes my day. And I can't do it because of COVID right now, but I can't tell you what it means to people when you incorporate both their medical care and their spiritual care. And I have chills right now to think of some of the times when I entered rooms and found out how important this really was to people. So thank you both for your presentations. And once again, guys, this is a tremendous area of where we really can make an impact as a spiritual community.
Thank you, Wayne. I appreciate your comment.
Hi, Marta. I used to work with Marta down there.
Yes, Marta's at Jefferson. Yes. Mary Jane Burke, did you have a question? I saw your hand wave. You're on mute.
You're on mute.
Sorry, that was an error on my part.
No problem.
I was clapping. I did want to thank everybody, and especially our presenters. Phenomenal presentation, really something that we need, very helpful, and I certainly will be using this in my daily practice.
Thank you for your comments, Mary Jane.
Oh, you're welcome.
And we can talk more.
Yeah. Dr. Lopez is very willing to help us with education.
Love to.
And awareness. Yes, thank you. Prevention is key, it sounds like, Dr. Lopez.
Dr. Lopez, are there any significant changes with melanoma?
So there actually are a lot of new therapies. There are a lot of new therapies. And I often think about, our population because we're so close to the beach. And people go out there. So the first, I think it's really sun safety. And I think sun safety needs to start with the babies. Whether it's sunscreen, being protected, not being out in the middle of the day, hat wearing. We could do a campaign this summer. I would love it. I am all about prevention. Let's educate people. Let's get them to, I don't know, we could come up with a catchy slogan, cover up.
Yeah, something, yeah.
Cover up, funds up or something. But yeah, I just think it would be that's the first step. And the thing with melanoma, yes, there really are a lot of therapies. I did most of my work in Arizona. Arizona, outside of Australia, has the highest incidence of melanoma in the world.
Wow.
So it's a high rate. And you see young people with this very, very difficult disease. It's come a long way from there in the 20 years, but it's not easy. It's not an easy diagnosis.
I have a thank you from one of our participants to Reverend McCray. I will be following up with this fantastic work. Thank you.
Fantastic. I appreciate that. And I omitted to say, just for the purpose of authenticity, I am now close to 2 years now a colon cancer survivor of early stage 1 colon cancer. So I am now a member of the club after 20 plus years speaking to this audience. I am among the rank and file. So I am very passionately connected to this message and to this audience on every level. So thank you so much.
Absolutely. Thank you. Thank you for sharing that, Reverend Percy.
Yeah.
Anyone else? I don't see any more
There's-
There you
No,
go. Hi,
yeah, I
Frank.
see.
How you
Frank.
doing?
Hi, Frank. How are you?
Hi, okay. Let me tell you, Reverend, I'm a survivor too from 2000, colon
Yay!
cancer,
Yay!
stage 2. So, okay, hang in there for another 3, then you get your survivor pin, right? Once you reach 5. And I got 2 questions. I had one was when I got my colon cancer, everybody used to get, I guess if you had colon rectal cancer, you got the chemo and you got the radiation. My colon cancer was up high around my liver and all that. And I just got the chemo. And I asked my oncologist to say, I felt like I was getting cheated. How come I'm not getting radiation? He says, well, you got too many organs there. He says, and the radiation wouldn't be good. And it just sterilizes the area. That's all the radiation does. So I always question, like, what is the importance then of the radiation? If you have all your chemo, why are you just sterilizing the area if the chemo is really killing everything?
Sure. So usually it's rectal cancer when it's, like you said, when it's lower down, right? And part of it is that you can't, in that part of the body, you can't necessarily get as clean of a removal. So where you are in the rectal area, if you imagine there's a tumor, that tumor, although it looks like it's all together, we could say what's called a field defect. So you have some spots that may be around that, okay? When you do surgery in an area where you can really easily see the area and you can easily remove it, which is higher up in the colon, then you may be able to take really more of what's there. Whereas when you're in an area where it's more difficult to really get it all out, then having the boost of radiation helps because it takes care of any of the cells that may be kind of let loose. It's like with breast cancer. You have the tumor, but we know that there are people that recur later, and because they're little cells locally that are left behind. So you remove the cancer, you radiate the area so you can remove those cells as well.
Okay, thank you. And the other question, and after listening to Reverend here, how does his program would maybe give us in Stephen Ministry as like a continuous education thing, so that if we get somebody who's like a care receiver who's going through cancer or something like that, we would have this in our toolbox too, because I don't know how long his sessions are. I mean, we've already gone through what, 40 hours of training as a Stephen minister, so I don't know.
That's a great question. Many of our cohorts actually have gone through the Stevens Ministry, which is a fantastic program. And so 2 key differences that I think will speak to specifically the question at hand is, number one, not as a negative comment in any way, because again, the Stevens Ministry program is fantastic, is that our program is free. So there is no cost to any element of the training, and that the totality of the training for the cohorts are 2 half days. So basically it's about, when you add the 2 days together, it's about 8 hours total that will need to be committed to receiving the core information that will be provided to you, that then you can take back with you, which is the design of it, so that then you can begin to recruit. Or if you have a cancer care ministry or a healthcare ministry, some churches already have employed that, many do not, but then you can implement any and all of the precepts of the curriculum in your, as a continuation of your Stevens Ministry training, and then apply it accordingly. The key thing that I would say to this is that we are not here to dictate to you, your local church, what to do with this material. You can shape and fashion it and implement it in any way that you deem necessary for your ongoing ministry, for a continuation or to start a new ministry, and then implement and disseminate that information accordingly. So it's yours to use any way that you choose to.
Right. We could do that online by watching your videos.
That is correct. It is all the training now, because of COVID. We've done it now for a year. It's all virtual. Yes, sir.
Okay.
Also, I'd like to, Father, would you like to, Father Sanji, he's the director of Stephen Ministry here at the Diocese of Camden. Would you like to say anything to add to that?
Again, as Anne probably mentioned, we do have many of our, Stephen ministers, a good number, not many, who have been trained in the cancer care ministry.
Mhm.
A lot of them are on the screen too.
Yeah, there are a few on the screen too. Yes.
Mhm.
Yes.
Yeah, and let me send a shout out. The parish nurses and the Stevens ministers, when we first started, were the first community organized group that embraced our journey of hope, when everyone else was still a little reluctant about it, because parish nurses and Stevens ministry understood the concept of practical ministry inside of the local church. So I just want to send a huge thank you and shout out to both of you guys. You were some of our biggest endorsers and still continue to be so.
Thank you. Thank you. Father, did you want to share? Did you want to share anything else?
No, I'm good. Thank you.
Okay. All right. Wonderful. Sandy,
So,
I see
C.
you.
Liberati had a question.
Yeah, C. Liberati also had a question. Yeah.
Okay, I'll come back to you, Sandy. Chris, you're on mute.
She's still mute. Chris, you're still
You're on
muted.
mute. You're on
Chris,
mute.
you're still on mute.
Can we, Anne, can you unmute
Can
her?
Can you hear me now?
Go ahead.
What can I do for my cancer receiver who is in constant pain? She had lung cancer and it was healed. She had surgery, it spread to her right femur, and she had surgery, and then she had radiation. And it seems that the radiation is the problem. She was told by her palliative care doctor that it's not that she was, the surgery was wrong or whatever. It's that her nerves are reacting to the radiation. And it's a very small amount of people that ever get this condition, but she's in constant pain. She cannot walk anymore. She's in a wheelchair. And even with the pain treatment, she's in constant pain. I visit her, I shop for her, try to spend time, social time with her, but she is just in constant pain. And she does not want to go to rehab, and she is trying her best to live on her own with the help of people. Is there anything that they can do for her pain?
She's been to a pain doctor?
Yeah, she was on methadone. I think she's still on methadone. She was on morphine. They put her on fentanyl, I think, if I say that correctly. And they basically are saying, just use the marijuana. She doesn't want to just be drugged up all day. And this is kind of where she's at.
So, I mean, it's really hard to say without, seeing a person, but there can be topical medications that could be used. Physical therapy may definitely be helpful. Sometimes nerve blocks are used for pain. So I think, and there's, the approaches that are mind-body approaches can also be really helpful. So I think all of these can be part of a pain management plan.
Thank you.
Thank you. Sandy, did you have a question? You're on mute. Do you want me? I could take you off. Go ahead.
Yes, I actually had two. One, Dr. Lopez, are there new advances in the treatment of the leukemias? I know leukemia is very difficult to have success with. And two, from what I understood, chemotherapy attacks all cells, good cells, and cancer cells. Has there been any advancement to target just the cancer cells?
Yeah, so that's part of trying to figure out the molecular biology, the genetics, and then being able to say, okay, here's a target and trying to go for it. Now, we do have some of those therapies. Some vary, by different cancers. We used to think, oh, that's great. We've got a target. This will be so much better. I think it's just different. There are different side effects. It may be better in the long run in the sense that the usual side effects of having people, or the biggest risk of having people, have their white count drop and having infection risk is often less. But there are other side effects. So it's not medicines without side effects. As far as leukemia, there definitely are newer treatments. And one of the things is if you look back, remember the slide where it's like, it takes time for a cancer to develop. That's often true about leukemia, which also means then that older people are often the people at risk for many cancers. It just, the risk often increases with age. So there'd be a large group of people that would have a diagnosis of leukemia. It'd be very difficult to treat because our treatments for leukemia were so difficult. And now there are treatments that, may be still an injection, but that they are better able to be tolerated. They are gentler for the person so that more people can get the therapy. So there definitely are developments in all the types of cancers, and some that are really effective for older folks, for folks that are frailer, and can result in at least some control of the disease.
Thank you, doctor.
Sure.
Okay, at this time I have no other questions. Marta, I just see your hand up. I'll take you off of mute. It's not allowing me. Are you?
Okay.
What's the difference between skin cancer, squamous cell, which is the second, then the other one is melanoma? What's actually the difference between the two cancers? I've had both, so I'm just curious. Or I do have both.
Marianne, is that coming from you?
It's coming from my husband.
I have a hard time hearing him.
Repeat it, Maria, sorry.
Okay, he wanted to know if there was a difference between the squamous cells and the melanoma cells,
Okay.
because he's had both.
Okay.
Yeah, so they are both skin cancers. Am I off mute? Yeah. So they are both skin cancers, but the squamous cell carcinoma is a more, it's more well-defined. It's more something, it appears like this scaly, lesion, sometimes a little bit of a thickened area. It's something that you can more easily go in and just scoop out. Melanoma is a more serious form of cancer. It's coming from a different cell. So the squamous cell is a different, it's a skin cell, whereas the melanoma is coming from the cells that have the pigment, so a melanocyte. And these are more aggressive types of cancer.
Okay.
So they're coming from a different cell. They have a different natural history.
Okay. All right, thank you. Marta, and then I'll come to you, Ann. I see you have a question too. So Marta, you want to ask your question?
Yes. Dr. Lopez, we just had a daughter of our friend was diagnosed with stage 3 breast cancer, and she is also 3 months pregnant. And now she's being advised to go for chemotherapy for so many weeks until her delivery. My concern right now is that about the baby, and what's the new thing about pregnancy and also chemotherapy right now?
Yeah, so this happens. We see this, and yes, there are some chemotherapies that are safe during pregnancy. So that definitely can be an indication, and And there are situations, where definitely the pregnancy continues, the chemo continues, and after the delivery, there can be more definitive therapy. But yes, there are treatments that are safe.
Thank you.
Anne, would you like
Good
to
luck.
ask a
Good luck.
question?
Okay.
Are you on mute?
Yeah,
There we go.
There you go.
Just a quick comment. I'm a palliative care NP, and the caller that was talking about I could hear her frustration and pain about someone in her parish or her faith community with bone pain, and the frustration of not being able to control it. I see patients in their home, and sometimes patients will they will tell you something in their home that they may not say in the physician's office. Okay, maybe this person could accompany her to the palliative care appointment and state about the bone pain, and then get a more full picture of what's going on, and then look at different options when she can actually accompany the patient. Go with her to the appointment. That would be an offering.
Thank you, Anne. That's a great point to bring up.
Thanks, Anne. Okay, I think we are pretty good on questions. Oh, Frank, you're waving your hand. You're on mute. I'm going to try to unmute you.
I got you. I'm unmuted. With all our different hospitals like Fox Chase and Anderson Cooper and University of Pennsylvania, do certain ones specialize better with certain cancers, or are they all just basically the same and they all have to use the same techniques to attack any cancer?
Well, I can't say that I'm unbiased.
Oh, yeah.
But so there definitely are standard approaches. And there are some places that may have, somebody that really focuses in one area or another. I don't honestly know that to be able to say.
Okay.
Outside of uveal melanoma, that's like a really subspecialty. But yes, there are general protocols, and there are definitely specific guidelines that we all use. And there are, and then there are studies, there are clinical trials. And sometimes the clinical trials can differ from place to place.
Oh, okay. That's what I was going to ask next. Yeah, did certain ones have more insight into a clinical trial than another one or something?
It really varies. Again,
Okay.
it could be that we have what are called cooperative groups. And those studies, let's say that in one place, they see a lot of lung cancer, so maybe they have more lung cancer trials. And in another place, they see a lot of colon cancer, so they have more colon cancer trials. But you can go to cancer.gov and you can see all the trials in the country.
Oh, okay. That's good.
Okay, I think we're good. Reverend Percy, did you want to say something?
Just one last comment, if I might have a shameless plug. You mentioned earlier that I facilitate a weekly podcast.
Yep.
So I'd like to offer that information to everyone, healthhopeandinspiration.com. And we interview cancer patients, oncologists, nutritionists, and we talk about all things cancer related and how faith and spirituality may play an important role with that journey. So please feel free to share that with your parishes, and please feel free to go online to our homepage, healthhopeandinspiration.com, and you will hear some wonderful inspirational interviews of real stories, real patients, real time. Thank you.
I just listed that on the chat for everyone to see.
Good.
Okay, Deacon Jerry, did you want to speak a few minutes?
Yeah, sure. Just a few seconds here. First of all, on behalf of Vitality Catholic Healthcare Services here in the Camden Diocese, I certainly want to thank Dr. Lopez and Reverend McCray for your time today.
You're welcome.
I could say that we truly appreciate your sharing with us all this great information about cancer and cancer care and cancer support. I know that we've been very well served by your discussions and presentations today, and certainly know that our diocese is well served by those parishes that have certainly embraced our Journey of Hope cancer ministry.
Oh, thank you.
So we thank you for that. Again, our greatest appreciation for what you've done in taking this time out today. So before we depart, maybe we could just take a moment and let us pray. Dear God, we thank you for giving us this time together, knowing that you are always with us. We ask your blessing upon those who have given their time and their talents to speak with us today. We're forever grateful for their dedication and their generosity in hearing your call to serve those who suffer the trials and the pains of cancer. We ask for your kindness and blessing as well upon all those who have participated with us today. May their lives be enriched by the knowledge gained through this webinar. And Heavenly Father, we sincerely pray for all those who are battling cancer. Build fearlessness and hope into their hearts each day. Give them solace when in pain and ease their suffering. And bring them healing according to your will. Bless their loved ones and their caregivers with the strength to help them through this most difficult time. We ask all this as we ask all good things through your Son, Jesus Christ. And may the Lord bless you and keep you. May his face shine upon you with joy. May he be gracious to you and give you his peace. In the name of the Father and the Son and the Holy Spirit. Amen.
Amen.
God bless you, everyone.
All right.
Thank you.
Thank
Dick
you.
and Jerry.
Thank you all so much for joining us.
Thank you
It's
so much.
truly a pleasure.
Yeah. Thank you, Dr. Lopez and Reverend.
Thank you so much.
Thank you very much. Have a wonderful day, everyone.
Thank you.
Thanks, Paul. Thank you.
Thank you.